There we go. We are live. So I'm just going to turn the comments on. So hello, Facebook world. We're back for another Monday night Facebook Live. So Eric and I were talking, and we've had some pretty good uptake on our podcast recently. So we thought what we would do is go through our last two that we did. One was from a Biolosky paper that talked about the mechanisms of manual therapy, and the other one was talking about the psoas and some of the myths and things around that. So we thought we would jump in and take a look at that and have a little chat about it. So I think it's probably good for us to start with talking about the mechanisms of manual therapy, because that will lend itself well to talking about the psoas and what goes on with that.
Yeah, I think it's great. I think when we talk about the mechanisms of manual therapy, kind of that applies to any topic we want to talk about, really, for what we do. So I think it's super valuable for that. I also want to say too, I think it's great that Jamie and I were talking off air how pleasantly surprised we are with the uptake for the podcast, the Massage Therapist Development Initiative podcast, because we just hit 1,000 downloads.
Yeah,
which is great. Yeah.
Yeah. And it was interesting because when we looked at the downloads, the one that was downloaded the most is the one on the psoas, and a lot of what that was about was looking at some of the myths and things around, or the beliefs, anyways, around the psoas. So it's really encouraging for us to see that people are interested in learning about that, which is, of course, lending itself to becoming more evidence-based as a profession or as a therapist. So that's really encouraging for us to see.
I guess it would be encouraging, though. I haven't looked to see the comments or ratings for the episode either. So there might be a lot of haters out there.
Yeah, and that's fine too. But
yeah, I don't know. At the very least, with the stuff we're doing, we want to make sure that we want people to start thinking and to question their thoughts and their beliefs, and to be less wrong about it. So yeah, hopefully, if you didn't like it, then hopefully at the very least you started maybe gave you some food for thought a little bit, thinking differently about it. Yeah.
Okay, so you want to get into the
sure.
note that I've got on the Biolosky paper here, and so I think the one thing, and it's something we've been saying for years, is that all techniques work the same. And you made up that great Matrix meme.
Oh yeah.
And then I copied it a couple of weeks ago and put it up. But just that all techniques work the same. And one of the things that I really liked about this paper is they weren't comparing like a modality title technique. They were looking and saying, whether it's a spinal manipulation, a joint mold, Swedish massage, all of these things work the same way. It's all a neurophysiological input that we're giving to the nervous system that in turn results in change. Not many of the weird narratives that are surrounding some of the modality empires out there that are preaching something that is dramatically different than that.
Yeah, we could even play a fun little game where I could give you the name of a treatment and then you could give me its mechanism. You're like, okay,
its actual mechanism or
the actual mechanism.
Okay.
Okay. So we'll go spinal manipulative therapy.
Interacts with the nervous system.
Yeah, there we go. We'll go joint mobilizations.
Interaction with the nervous system.
There we go. Swedish massage.
Interaction with the nervous system.
Let's go myofascial massage.
Interaction with the nervous system.
Yeah, let's go craniosacral.
Another interaction with the nervous system.
We can pick everything. Trigger points.
An interaction with the nervous system.
Yeah, everything. I mean, we could go and we could play this game all night. We could choose a million different things, but really, I think the thing is that we need to emphasize. And the reason we did the podcast on it, and the reason we're doing this, is we wanted everybody to realize that there's a million different ways. Maybe I shouldn't say million. There's dozens or many dozens of different ways of treating somebody, and each one is totally valid in its application because they're all just different ways of interacting with someone else, the human and their nervous system. And we know the effects are a combination of kind of neurophysiological from the touch, as well as the context and the non-specific effects of the whole treatment ritual. And I think the thing we really want to emphasize is that we're not disputing that those ways of approaching somebody aren't okay, but the mechanisms behind them are all the same.
Yeah.
And everyone has their own preference for the way they like to touch, the way they like to do things. Every patient has their own way of things that work for them or don't work well for them. we have this level of comfort, this level of experience and expertise that we all have, and our patients have their own expectations. So our treatments, we don't need to keep on searching for a million different ways of touching people, because the mechanisms behind them are all the same. It's a matter of finding out what works for you and what works best for the person in front of you.
Yeah, and what the person in front of you likes.
Yeah.
You know, I mean, one of the big reasons that they come to you is because they like you and they like the treatment that you do.
Yeah.
They like the way that you touch them. So keep doing what you're doing. Just change that narrative around it, if you're still using the old narrative.
Yeah. And I think that's the thing that's really important, because I think some of the feedback and conversations I've had with people over the years are, you know, when people hear about like evidence-based, or they hear about pain science, oftentimes what people hear is that we're trying to like remove things from practice. Like we're trying to promote a more evidence-informed narrative. People that really hold on to their modality, like the specific modalities, they hear that we're saying it's useless and it's garbage and they should stop. Mm-hmm. That's oftentimes what people hear, but that's not what we're saying at all.
Yeah.
So we'll say it right now live on Facebook, and anyone that watches this now or later, that's not what we're saying. We're saying you can still do those things. I mean, we can't tell you what to do, but
you should be doing those things.
Yeah, and I think the thing that's really important is that what we're trying to say is that the stories and the beliefs about those things are not supported. And I think we, as a healthcare profession, when we want to have respect and we want to have we want to be the most effective that we can within the kind of the musculoskeletal healthcare world, we really need to adopt current evidence and the current narratives and stories that a lot of people hold on to aren't supported by that. So we need to put those narratives and stories to the side and try and everybody come together, and what can we agree on? And we can agree on that touch, movement, communication, the whole treatment package is beneficial.
Mm-hmm. And I think, and I know that we use it when we teach, and we've seen it so many times, but the Eric Mera evidence-based funnel is just phenomenal, because there's things in that talk about like the best evidence, or the newest and best evidence research that's out there. But part of it is also your clinical experience. That's a huge part of being an evidence-based practitioner. So no one's discounting that what you do works and that you're good at what you do. And that, you know, when somebody comes in who has, say, low back pain, that the way that you treat them and the way that you help them actually helps them. No one's questioning that. And that's a big part of being an evidence-based practitioner is that clinical experience. So please keep using your clinical experience, but maybe just change the description that you're giving to people about what's happening when you're working on them.
I think you see that oftentimes too, you know, people that are like on Facebook, which is kind of tends to be the social media platform of choice for us and for a lot of people, is that people will get in these arguments online about, well, in my experience, therefore I know it works. Mm-hmm. So, and oftentimes people will have this hypothesis or this belief about something, and then they'll do a treatment and they get positive results, and they use that positive result from the treatment as proof that their hypothesis is true.
Yeah.
No, all you haven't proven your hypothesis. You've proven that your interaction with that person made them feel better, but it doesn't mean that you realigned or balanced or changed or fixed something in the person. It just means that it's had some beneficial effect, but it doesn't mean that your proposed mechanisms are valid. Yeah, and I think that's a really big distinction, and I think that's really important for people to understand, is that you're getting your results, and obviously you wouldn't be in practice for, say, 25 years, for example, and have a full patient load if you weren't doing stuff that helped. Mm-hmm. We know that you're doing something that helped, but maybe the reasons for why it's helping are different from what you think.
Yeah,
and that's okay. But let's just change the idea behind it, and maybe you'll be even more effective.
Yeah.
Who knows?
And I mean, that's one argument that I see too, is when people are using that argument of, you know, I have repeat clients that I've seen every week for the last 25 years. Well, that doesn't really indicate that you're successful at treating. Right. You may be successful at having people come back, but if somebody has to come back that often, unless it's just the fact that they have money and they really like getting a massage once a week, then by all means, keep doing that. But I don't think we can use a consistent repeat client coming in as proof that what we're doing works.
Yeah, I think that's always a thing, and that we talk about too, right? And we've talked about this all the time in our courses, and I think we've probably mentioned this on a few of the podcasts. Is that some people want to come in all the time, and that's fine, that's great. Yeah. But the stuff we're talking about is when someone feels they have to come in to see you, and maybe they have some systemic, long-term health condition, and you're providing quality of life. Great. Then that's fine. But we're talking with people that become dependent. And they're like, I need you to see me all the time because I've got this low back pain, and you're the only one that can fix it. That's the time when we're like, okay, let's start thinking maybe there might be a different story or belief or narrative around here that we need to maybe address.
Yeah. Totally. And for anybody who's watching, we also encourage you to grab your favorite beverage, because I've got a good scotch going, and I think Eric's got a glass of wine. I just got
a glass. I just poured a glass of red wine. Just had dinner and have a wine before a chat.
Nice. So we encourage anybody watching to join in and have a beverage with us.
Yeah, maybe if people want to put in the chats where they're.
Yeah, whoever's listening in, tell us where you are and what beverage you're having with us.
Is anybody watching?
It looks like there's 20 people on right now.
Oh,
a few likes there already. So
okay, perfect.
Hopefully we get a little interaction from people.
Yeah.
So if we dig into the paper a little bit, and of
sure,
course
I've
got notes from what I made up. One of a few of the points that I liked is when we look at Laura Alexander from Toronto. She's having a Yorkshire tea. J.R. Stacy from Chilliwack. Sophia Berg says hi, but where are you from, Sophia? Where are you? Carl Lester from Melbourne, Australia. Man, we got Canada, Australia, the UK. Love it.
Wow. Thanks for joining us, guys.
Love it a lot.
The UK, isn't it like 5 o'clock in the morning or 3 o'clock in the morning in the UK? It would be 8 hours ahead.
Is it 8 hours?
Yeah.
Jocelyn's on it. She's having a fat tug. Love it.
Okay.
I enjoy a good fat tug as well. Corinne Diamond from Fernie, BC. Fernie, Corinne, we're going to be up in Nelson in June. You should come and hang out with us. Same with you, Sophia Berg in Prince George.
Oh, yeah. Come join us.
Yeah, we've got a course going on up there. Laura, 2:14 in the morning. Wow. 1:15 p.m. in Aussie. Wow. What are you doing up at 2:14 a.m.? I would be knocked right out at 2:14 a.m.
Wow. Well, appreciate it. Thank you.
Yeah, thank you so much that you're taking the time to spend with us at 2 in the morning.
It's probably because she knows that we'll put her to sleep. Talk about some papers, some research papers. She'll be like, okay, I'm done.
It's like
all I needed to calm down.
It's like a meditation thing in the background. She's just listening in, and it's gradually just drifting her off to sleep.
Yeah.
Okay, so if we talk about the chocolate o'clock in London, Danny, that's great. So getting back to the paper a little bit.
Oh yeah, we're getting distracted.
The whole point that we were here. So one of the things that I liked is that manual therapy interventions are multifaceted that compromise specific and non-specific factors: patient, provider, environment in which the treatment is provided. Oh, Laura, you're in Toronto. Sorry. I thought UK, but Laura's in Toronto, so it's
Toronto. Yeah, yeah. Laura Alexander. We know her. Yeah, she's in Toronto. Yeah.
Yeah. Okay. So back to the paper. Manual therapy interventions are multifaceted that comprise specific and non-specific factors, including patient, provider, environment in which the treatment is provided. So that's just a little hint towards some of the contextual factors that are at play when we are helping somebody in delivering a treatment. And I think one of the examples that I like to use is, if you take an athlete and you give them treatment within the surroundings of their sport, within the surroundings of their team, within all of those other things, when we look at environment, you're probably going to have a better outcome than if you completely remove them from all those things. Unless it's that they actually need a break from all those things. Then maybe being in a clinic and being away from everything is going to have a bigger benefit. So that's just one of the simple things when we look at environment. And even, I know, Eric, you guys changed the whole look of your clinic. So that clinic environment to make it look more like an inviting living room space. in order to change that environment in the hopes of having better outcomes with your people. So I don't know if you want to actually touch on that with what you guys did in the clinic.
Yeah, we just decided to move it away from it. It kind of felt like a doctor's office type thing where it was just kind of plain and kind of medical. And we actually, yeah, we changed it. We got rid. There's no, like, as you come in, there's just like nice chairs there, and there's like some nice art, and a big plant in the corner, and the desk is like wood, and it's like a nice kind of light, like grayish white trim on it. And there's nothing in the waiting room that looks at all medical, other than there's like a desk with receptionists there. I guess it probably looks a little bit more medical now with COVID, because everyone's got masks on, and there's signs about don't touch each other and stay away from each other, kind of stuff like that. But yeah, we just did it to make it more comfortable.
Mm-hmm.
And yeah, our patients like it. I mean, we've had really good feedback, and our therapists like it because it just feels more comfortable as a place to be more, there's not that stress or anxiety about, that kind of white coat syndrome.
Mm-hmm.
Yeah.
One of the things I like about it is there's a book about my favorite hockey team right on the when you're sitting there.
Yeah. The Maple Leafs. Yeah. We had to move away all the reading material, but yeah, it'll go back out once we get past COVID here.
Nice. So that was another point that's brought out in the paper, is that we can't look at our modalities as the thing that's necessarily getting people better, because we can't look at a single well-defined mechanism. A single well-defined mechanism is unlikely. Outcomes are related to varying contextual factors. Yeah. So the environment, what the patient's going through, what their beliefs are, what their expectations are, as well as what you as the clinician are saying to them, and whether they like you or not. Even how you're dressed can make a difference. And we joke around about how you're much more formal than I am. You dress much nicer than I do, and I look like a bum most of the time because I'm just in shorts and a t-shirt. And that's why, certain people would prefer to come to you and other people would prefer to come to me because of, a couple of those minor differences. But those are all things that play into having successful treatments or even unsuccessful treatments, depending on the choices of the patient.
Yeah, actually today I was actually before this, I actually had like sweats and like a gray hoodie on. And so I was like, well, going online, I should probably put on a different shirt. I still have my sweatpants on.
Nice.
That's a great thing about it. I'm
still in shorts and a t-shirt.
Yeah. That's funny.
Nice.
Yeah, one thing I think, these guys, Bielowski and Bishop and the group, they've done a lot of other really good papers, which are really interesting about, the mechanisms of manual therapy and the whole kind of effects of what happens during a treatment. And, and I like they've made a couple of very blatant quotes in this paper, which I thought were really good. And one of them was, it basically just says the biological effects of a treatment should be established. Mm-hmm. Like if there's no evidence to say otherwise, then we have to go with like what we know about the biology. And we talk about this all the time, about the biological plausibility. And they say here too, we believe that research focusing on individual mechanisms in isolation will always fall short of providing meaningful insight. Mm-hmm. And I think that's a really important point, because when we're looking at what we're doing with people, we know that, say someone goes to see a myofascial therapist, or they get to see someone that does like Swedish, or versus someone that comes from like a myofascial release background, or however they identify the type of, or visceral, or whatever they identify as, they get outcomes with their patients. Mm-hmm. But the reasons why they're getting them, though, aren't because they are doing something specific and they're not affecting some specific individual mechanism. It's part of the overall treatment that's providing that benefit. And I think if we just stop arguing about who's right and who's wrong, and I hate that all the time. And when people are like, well, I do this and it works. And someone else says, well, I do this and it works. And you're like, okay, well, who's right and who's wrong? How can you both be right? Yeah, well, that goes back to that story that I use from college all the time, right? Between the myofascial release and the craniosacral class. And, I might as well tell it since I brought it up. But sure, yeah.
I would love to say that as a student, I was some forward-thinking genius that figured this out, but I clearly was not. But in term 2 of school for us, we had a myofascial release class, which I think was MFR 2. back then. So they showed us how to do an occipital hold. So, you get those fingers right up on the occiput, and the patient's relaxed and their head's falling into your fingers, and it feels really good. And then in term 7, we had the craniosacral class where they showed us the exact same technique, but they gave a wildly different explanation as to what was going on. In myofascial 2, it was you're releasing the fascia. In the craniosacral class, it was that you're altering the rhythm of the craniosacral fluid and you're altering the sutures in the skull. And I was a bit of a jerk in that class because when they were asking about whether we felt the pulses of fluid and all that, I was like, no, I don't feel anything. And classmates were like, I feel it. And I'm like, you're full of shit. You don't feel anything. There's, my ego was probably getting in the way of that a lot. But looking back on it, years later, I go, well, they showed us the exact same technique, but gave us wildly different explanations. So which one's right? And just as our buddy Jocelyn says, everyone's wrong. Because neither of those are right. But they have such a wildly different explanation. And for whatever reason, therapists like to grab onto that and think that they're having that effect. When in reality, when we look at that occipital hold, it's something that feels really good. And it's a highly innervated area with nervous tissue. And when we're doing that, we're interacting with the nervous system and doing something that feels really good. So it is a very effective technique to use. It works great. It feels good, but it doesn't do the things that they said it did.
I think what happens oftentimes in these conversations too is that people are like, well, what am I supposed to do now then? That's the question we get all the time. What am I supposed to do now? Well, you do the same thing. I'm not saying you have to touch people differently if it feels good, right? If our goal as a therapist is to decrease kind of that sensory aspect of pain, to maybe instill a little bit of more confidence and belief, and a little bit more comfortable range of motion, maybe help them reconceptualize and think differently about what is that's going on in their body, then we don't really have to do much different.
Yeah.
And I think that's the key thing. But I mean, we've been talking about this for so long now. It seems like we've been having this same conversation with people for years and years and years and years. Yet the kind of old narratives keep on sticking around because they're nice and clean and they're easy. They're very linear. They're very A equals B.
Yeah.
And I think we just need to accept that things aren't that clear. And we can spend all day arguing dogma with people about, how something works or doesn't work, or what's the least wrong or the best explanation for it. But I think the thing that's really important is let's look at the things that are common. Mm-hmm. Like, let's look for some common ground in these things. And I think if we could all agree that our touch has some type of neurophysiological impact on the person, then it's a matter of our own comfort level, our own confidence, and that of the patient and that's all that really matters.
Yeah. It's funny when you were saying that, I kept thinking back to, I was trying to read some of the questions, but I kept thinking back to when I was a kid and me and my brother used to fight and my mother would just shout out, "Can't we all just get along?"
Oh. It'd be so much easier if we could.
Yeah. If we could just all come to an agreement that, touching people nicely is probably just the best explanation we can use. So Taylor's got a comment, Jocelyn's got a comment, Laura had some comments, but they keep getting cut off. So let's just quickly jump into Laura's here and see if the whole
if you want to bring them up, we can see them.
Thing is there. Okay, so this is where it kind of lost me because Laura, you're talking about the topic of blankets, but then for some reason, I don't know if you left the rest of the comment, but you said it would be a deal breaker for you because, and then it cuts off. And there's nothing there, so I'm not sure what to add to that. So
I don't know why you wouldn't want to use blankets in treatment in a clinic if that was something that you liked or your patients liked. I don't know.
Yeah, it helps keep people warm.
Yeah,
it's great. So Taylor, can you comment on how the therapist's expectations and beliefs affect treatment outcomes? Follow-up question. If someone believes in something, is it better than believing in nothing? That kind of goes back to a bunch of the stuff in the Darlow papers when we're talking about therapist beliefs. So I think that goes back to a lot of what we've been talking about. Like if you followed some of these modalities and that becomes your belief system and you're telling patients that the only way that they can get better is if you're going to do this treatment thing that affects your craniosacral fluid and whatever else, then those things end up becoming part of the patient's belief system. So then they think that every time there's something wrong, the only way that it can get fixed is by having that specific thing happen. And granted, you can have a good treatment outcome with it, but to me, that's when they end up becoming dependent on, oh, I have to get that therapist to do this thing to me, because they believe that that's the thing that fixes them when it's not.
Yeah. I think it's, if you look at something like, for example, every time I say somebody has, I don't know, pain kind of along the, I don't know, medial border of the scapula, and they go and they're like, oh yeah, something's there. And they go for treatment. They're like, your rib is out. And then you do a treatment and you mobilize and you massage and you put the rib back in. Every time they feel there, and I think, I don't have references off the top of my head, but I know I've read this before, that when people have those things and you confirm that there's something wrong, and you go and you provide a treatment that fixes that area, makes it feel better, every time they feel any type of sensation in that area, they can often will go and say, oh, like it must be, my rib must be out, therefore I must go get
it put back in.
Go get it put back in. So it can create these kind of drivers for treatment that may not be necessary.
Yeah.
And there's some cool research that they've looked at too, where they've given like they've blinded, in drug studies, they've blinded the researchers to think that they're giving somebody an analgesic drug, for example, and then the person will actually have higher reported pain relief when the therapist thinks they're giving them the drug, even though the therapist isn't.
Well, that was that paper that Corey shared with me. That's all about the ultrasound.
The ultrasound one too is another one. You've want to talk about that?
For those of you who don't know about that paper, and I'm doing this from memory. So what they did is they took therapists and patients, and they were going to use ultrasound on them for whatever their ailment was. So just therapeutic ultrasound, like is what is common in a physiotherapy clinic. So I think the way that it went is, in the first setting, the patient believed that the machine was plugged in, but the physiotherapist knew that it wasn't. Physiotherapist went in, did some treatment, and the patient got 25% better. And then in the second one, the patient didn't know it was plugged in, but the therapist thought it was, and the patient got 50% better. And then in the third one, it went through, and they, it wasn't just like three simple things. There was groups of people that were going through this. And then the third one, the physiotherapist thought it would work, and the patient thought it would work, and the patients got 75% better. But the machine was never plugged in. So the machine never actually did anything, but it was the attitude and beliefs that made the difference in the treatment.
Yeah.
Crazy stuff.
Yeah, and I think there's so much. There's so much of the kind of contextual research, placebo type research that looks at that stuff. And yeah. I think to respond to the second part of Taylor's question there, it says, if someone believes in something, is that better than believing in nothing? I guess it depends what that something is. I think is how I would look at it. Is that something harmful? Is that something impacting their quality of life? I would say if it is, then I think we have the ethical obligation to try to have a conversation with them about it, to see if it's something that maybe should change. But if it's not impacting them, like we've all got patients, and I could say this myself, there are patients that come in that have non-evidence informed beliefs about their body, but it doesn't really impact them negatively. And I'm not going to bother trying to change that if they really hold on to those and it's not negatively impacting them.
Yeah.
That's how I feel with that anyway.
Yeah. And is that belief creating dependence on them coming to you to get treatment? Then, like you said, I think we have the ethical obligation to change that. So then we got, let's see, where did we go? Jocelyn. I'm curious what your thoughts are on modalities like CST and visceral that have taken up a nervous system explanation now, in that relaxing the nervous system and what causes shifts in sutures and visceral movements. I'll talk about the sutures. And I, as most people know, I have a pretty strong first aid background. When I was 18, I was working as a drywaller, and I fell something like 10 feet onto a concrete slab, and I fractured my skull 5 inches down this side. When I worked at the mill, and I've been through tons of car accidents where, seen people at high impact speeds and things like that, or saw guys at the mill who took 2x4s to the head, yet it didn't change their skull. It didn't cause a fracture. It didn't do anything. So to me, I look and go, if a 2x4 flying through the air hits somebody in the head and doesn't damage or change anything in their skull, how is 0.5 milligrams of pressure holding the occiput going to alter a suture in the skull? It's not plausible. So especially if we're relaxing the nervous system, why would it do anything to the sutures in our skull? There's absolutely no reason for a relaxed nervous system to have that effect, because the sutures in the skull aren't doing anything that's bad. They're holding the skull together. So why would we want to relax them?
I think that with those kind of explanations to, or those kind of ideas, is that first thing you have to do is you have to establish that a suture has an impact on someone's well-being.
Yeah.
And then you'd have to say, okay, we know that you'd have to prove or have some type of evidence to support that sutures can have a negative impact on someone's pain or headaches or concentration, whatever it might be. And then you'd have to prove or have some pretty good evidence to suggest that they can move. And in the absence of both those things, then that kind of throws out that explanation gets thrown away. And you look, well, what happens when we touch somebody, say someone's got headaches and you're putting your hands on them gently, doing a craniosacral type treatment. What is the least wrong explanation for that? And it's you're providing some type of sensory input that provides a feeling of safety or comfort in the area, along with the belief that you are doing something that's going to help them. The patient comes to you with this expectation that you are the person that's going to give them some relief. And you put those things together and you're probably going to have some type of positive treatment outcome. Doesn't mean your treatment outcome didn't work. It just worked for a different reason. Mm-hmm. And I think the thing is too, to add to Jocelyn's question there, she mentioned these cranial and visceral courses and other courses are they're throwing a lot of these other courses. The course creators and the people that teach them, a lot of times they're incorporating what I would call like neurobabble into them. Mm-hmm. Like the people are like, oh, well, we know that there's this pain science and things are neurophysiological, and they're like, how can we keep this treatment paradigm and keep it kind of like try and make it sound more current evidence-y? And a lot of them will start to throw in a lot of those kind of neuro explanation type things, and you see that a lot. And I think that if we could just all talk about what we know, that things are more stuff we've been talking about, neurophysiological, contextual based, then I think we would be further ahead. I think we'd be moving in the right direction, but I think it's just throwing that kind of neuro talk on top of the outdated narratives is not really a step in the right direction. It's kind of like 2 steps forward, kind of 2 steps back, maybe 1 step back. It's like not quite fully in. So I don't know. I see that and I think, well, you're trying, but you still have ways to go.
Yeah.
So we would say those people maybe are pain curious or evidence curious, but they might not fully be able to, they might not be fully jumped into the deep end.
Yeah. And hopefully it is that they're making the effort and they're trying to change.
Yeah.
Hopefully it is that they're putting the effort in and they're trying to change things. And, they just got another year of research to look at that'll get them caught up, and hopefully it means that the change is coming in.
Yeah. I know for me, like years ago when I first got into this stuff, I was kind of incorporating, because I came from like this very fascial, that was my mindset. And I was learning about kind of some of the neurophysiology and the pain science stuff, but I kept on taking that stuff and trying to apply it to the model I was operating under before. And I was trying to like fit, it's like trying to fit what's that saying? Square peg in a round hole. And I was like, these just don't fit, but they kind of do. And it took a while to kind of reconcile that, to realize, oh, okay, these don't fit this way, but we can still, there's a way we can make them fit, but let's just throw away the connective tissue explanation, do the same technique, put it together with a evidence-informed kind of neurophysiological explanation, and then it kind of fit. Mm-hmm. I think for some people, and I know from my own experience, that's kind of what happened with me. And then once it clicked, I was like, okay, I can accept this now. rather than fight against it.
Yeah. You know how sometimes you get that feeling where you hear something or you feel something and you kind of get that shiver down your back. And like for me, when it happens, I kind of end up like twisting my head a little bit when you get that feeling. I just bring that up because Laura just left this comment that said somebody went to a therapist who stuck their fingers in their ears. And as soon as I saw that, I was like, ugh, if somebody did that to me in a treatment, that would creep me out. I'm sure some people might like it, but that would just creep me right out if somebody did that. Okay, so it doesn't look like there's any more questions.
But keep them coming if you have them. These are great.
Yeah, because we came in and we were like, oh, let's talk about this stuff, and we've completely gone off in a kind of a different direction, but that's okay.
If anyone really wants to listen to us discuss these papers in general, they can just listen to the podcast on their own time. Yeah.
Sorry, I'm just looking at some of the notes that I made here. I'm trying to pick out what was some of the good stuff. Well, we kind of beat up most of the stuff from that paper. We could,
I mean, we could just read quotes off of it, but I mean, it's. I think we've made the point pretty clear. I think through stories and whatnot, and I think it's fine. I think the one thing I'm just looking at here, which I highlighted from this paper, and we discussed this in the podcast as well. I'm going to read this little quote here. It says, the model was designed. So they created in this paper, they created a model to kind of research the effects of manual therapy. And the model they created was designed to comprehensively account for the interacting mechanisms behind a complex manual therapy intervention. So the model was designed to account for the mechanism of manual therapy in pain inhibition. And so they looked at biomechanical effects, peripherally mediated effects, spinal cord mediated effects, and supraspinally mediated effects. And they wanted to acknowledge the potential for alternative plausible explanations to their findings should the study not account for competing mechanisms. So what they did is they basically they're like, we know there's something that happens in the tissue. We know there's things that happen in the peripheral nervous system, the spinal cord, and the brain. And we want people to do research to look at how these things are impacted by various manual therapy interventions. And I like how they said though that like this is just their ideas, and then but any future research should be focusing on plausible things that can be explained with research or with current understandings of anatomy, physiology, neurophysiology. I think it's great as someone who likes to read research to see them kind of leave that door open and say, hey, look, we're not saying this is the only thing. We're saying this stuff would be useful to know, but any future research has to be based on what we know that's plausible. Yeah. That's really important.
Which actually blends well into Taylor's next question. Just saying, do you think we're spending too much time focusing on criticizing mechanisms? I suppose there's part of it because we're like when we're criticizing it, we're not trying to beat up on those other explanations and those other outdated mechanisms, but we also don't move ahead until we update what's actually happening and until we have a mass movement of therapists that are speaking the same language. So I'm not sure how we can do it without at least being critical of some of those other things.
Yeah. I agree. I think because if we want to move forward and we want to be considered an evidence-informed profession, healthcare providers, then I think too much time. Well, I would stop talking about it if I every time I went online or we taught a course and we didn't see people discussing the wonderful world of all their different modalities. So I think until the dominant narrative becomes, let's just call it evidence informed, to be the kind of the terminology that people like to use. I think until the common narrative becomes evidence informed, then we can move away. But I think until, like you said, until we have enough people kind of willing to move past that, I think we're not going to move into the direction we want to. Yeah. And
Laura agrees with us.
Yeah, exactly. Yeah. And the narratives. And I think it's really important too, that to understand that the power of the words and the power of those narratives, the reason why we spend a lot of time talking about them is because in a lot of people, those can be harmful.
Yeah.
They can, or at the very least, they can be unhelpful.
Yeah. Probably doing more harm than good.
Yeah.
Evidence bias narratives. There you go, Joss.
Evidence bias narratives. Yeah.
On that one.
There we go.
Yeah. Okay, so we kind of beat the hell out of that paper. We can talk about stuff a little bit.
Talk about the psoas stuff.
Yeah.
Yeah, sure. Let's talk about psoas. That was the one that was the most read one. That's one everyone wanted to read about, or listen to. Sorry, the most downloaded one. So,
unfortunately, TJ's on here too. He could probably, well, I know he will leave a plethora of comments because he's actually much more well versed in the research behind the psoas than I am. I just looked at a couple papers for that podcast that we did, but I find it funny because it's that for whatever reason it seems to be that muscle that gets so much more attention than all the other ones. Calling it the muscle of the soul and the soul muscle, and that it's this huge hip flexor and all these other things. And I would just love to know why it gets so much attention, because I can't figure out why.
I think this is just totally, I'm just guessing. But I reflect back to my time in massage school, back in 2003 to 2005 when I was in massage school. And I remember we spent an inordinate amount of time learning about the psoas. Mm-hmm. We spent a lot of time learning about it in musculoskeletal 1 and 2, where we learned how not only did we have to study all muscles, but we spent that one too. We had to learn all the attachments, and we had to learn where it went and its mechanisms of action, like what it did. And then in musculoskeletal skills 2, we spent a lot of time about how to be very careful with palpating it. And you have an instructor that's very confident in telling you that this is responsible for most cases of unresolved low back pain and hip pain. And that was kind of and from talking to other people that have been to school as well, that kind of like was put on to the students, like this is a really important thing, and you gotta be very delicate with it, you gotta be very careful, because there's organs and there's stuff in the way. And so it almost creates this kind of mystical special aura around it, and I think it can, and it's kind of, and when you do a treatment on somebody, it's so profound because you're putting your hands in their abdomen and you're pushing in there and you're getting them to contract and relax and you're kind of sinking into that area, and it can be quite profound. So I think it kind of creates its own really powerful narrative behind it.
Yeah, and just as you were saying that, I came to the realization that you probably have to communicate with somebody way more when you're treating that compared to treating the quads.
Yeah.
Right. So there's so much more contextual factor to that treatment because of the extra communication, because you're making eye contact with them, because there's this extra level of discomfort or whatever that's associated with it. So there's probably way more contextual factors to that treatment than treating any other part of the body.
Totally. And I think, and you think about it too, right? You think, the abdominal area is such a sensitive kind of protective area for a lot of people. Like it's like your organs and stuff there. Like it's a very, it's a very, an area that is not touched a lot, and it's not something that you normally go as a therapist to go and work through, but to get at the psoas, you're kind of going through that area, which has got a lot of sensory receptors in there. There's got to be a lot of trust between the patient and you. So I think there's going to be a lot of other pieces of that build up into it. And I think, by trying to equate treating the psoas and I'm releasing that psoas, and that's the reason why the person feels better, you're kind of oversimplifying a very complicated treatment environment and kind of ritual of what you'd be doing to treat that area. Mm-hmm. And I think that oversimplification is unhelpful.
Yeah, and Kimberly makes a great point, the novelty of it for the client.
Yeah.
Right, more of the contextual factors that go into it.
It's novel, right? You're putting a novel stimuli in that area.
Yeah. And Laura makes another good point, just going back to the narrative stuff a little bit, that she used to be all about fascial stretch therapy. So she's got rid of that narrative, but she still does it because it feels nice.
Yeah. I love it, Laura. And that's perfect. That sums up exactly what we're trying to say, right? Is that it feels good. Do it.
You're gonna love the blog post I'm putting out tomorrow.
What's your blog post tomorrow? Oh, yeah, I know.
It's going to be a little bit of a cheeky one, saying that we're developing a new 4-stage course that has all these funny acronyms and stuff in it. So it's a bit of a tongue-in-cheek blog post, but I think it gets a point across. So
be prepared for about a couple dozen unsubscribes.
Yeah, more than likely. Yeah.
Yeah,
but that's okay.
Yeah.
Okay, so continuing on with psoas stuff, and this is where Taylor will probably jump in, because I know he left a couple comments on the Facebook page of when I put the blog post up that I wrote about it. And like I say, he's got way more of the research than I do on this. But one of the things is because, it's always been a hip flexor, or we were always taught that it was this major hip flexor, but it needs a 3-letter acronym. There's actually 4 different 3-letter acronyms that are in this blog post tomorrow, Laura. So hopefully you like it. But anyways, the psoas was always a hip flexor, but some of the research that I read said it's actually more of a lumbar back stabilizer than it is a hip flexor. So Taylor, I'm sure you're on the keyboard already typing in comments, but we need to look at that. There's more going on than maybe what Netter says. That muscles can have different function, and you talk to a lot of people that do cadaver labs and things like that, and quite often muscles aren't as big as we thought they were. They don't do as much as we thought they were, and it's can be quite different for different people. So psoas is definitely one of them.
I actually have an interesting story here, just talking about the whole kind of I'm going to use the word absurd, the absurdity of being able to change a muscle manually, like with our pressure. I did a course for a bunch of therapists in the UK early last week, and one of the guys messaged me after, and he was a chef for 20 years. And he made some comment, and I don't have it here in front of me, so I'm going to try and recall it, paraphrase it. He said, the only way I could ever change a muscle was with like a meat tenderizer or a scalpel. He's like, it never made sense to me when I was learning how to do massage that I could actually soften or change that muscle through my touch. He's like, it just never made any sense to me. And I thought it was so great, because he's like, this is somebody that's worked with meat as a chef for 20 years. And he's like, it's so tough. You can't change it. So why do people think that they can actually forcefully change it? It doesn't make sense. But then we're like, okay, well, and we also know too, and this is probably a different topic, but we know that the receptors in muscles don't respond very well to manual external pressure. Mm-hmm. Like the kind of neuroreceptors and the nociceptors and all the stuff that occurs in the muscle, that exists in the muscle, respond more to stretch and load, or to damage if there's inflammation. Right, that's what causes change, not through external pressure. So if someone is feeling a relief, and then so you think of those things, okay, look at the science, and you look at this guy's experience as someone that's worked with beat for 20 years. And you look at what we know about how that muscle tissue responds to load and stretch and external pressure. And we realize that massage actually can't forcefully change a muscle. But why do people feel better? What's the one mechanism that makes the most sense? And it's like, well, you're changing some type of neurophysiological response or sensory and perceptual response in that area that's having some type of effect at the peripheral, the spinal cord, and the cortical level. That makes way more sense.
Yeah. It's great. It makes tons more sense.
Why do we need to? So here's this is related to the psoas. Why do we think we need to actually go in there and push hard on the psoas to create a beneficial effect? I don't think you need to.
No. And that, I mean, to kind of go with that, part of what that research paper that I looked at, and we talked about the size and the role of the psoas, and it showed that I think it was like looking at the size, because the more you load it, the more it changes, and they're looking at possible hypertrophy or it shrinking in size because of lack of use. Yeah. And they looked at people who were in pain and were dealing with bed rest, that it was the same size as somebody who was an active cyclist. So there was no correlation between the size of it and activity level and back pain, things like that. So I thought that was super interesting when I looked at it. Okay, I knew Taylor would have something. This is great. The psoas major works in concert with iliacus during hip flexion tasks. It betrusses the spine during hip flexion activities and stiffens it through its compression abilities in order to help the lumbar spine not buckle into extension under hip flexion torque. So in this way, it can be looked at as a lumbar stabilizer, but only under large hip flexion torque. Interesting. Cool.
Great.
I like how he uses fancy words like betrusses. I don't think I've ever heard that word until I talked to Taylor.
Thanks, TJ, for sharing that. Yeah.
So it's more than just a hip flexor.
Yeah.
Yeah. So let's stop bastardizing it for these other things.
We should ask everyone that's watching. I don't know if anyone's still watching. We should. Is there any other muscles or any other parts of the body that people would like to hear more about? Because the psoas is magical, and this is what everyone wants to hear about. But is there anything else? What's the second most magical
muscle
or part of the body? That's something I'd be curious about.
Oh, this is interesting. Connor, he said they've also had a few therapists rupture an acute appendicitis or two. So I'm assuming that was somebody who came in with pain in that area, and therapists didn't realize it was an appendicitis and went in and treated. I'm guessing, Connor, if you can comment on that.
Wow. And I've heard that before, and I don't know if this is like just like one of those like stories that gets perpetuated amongst the students or amongst the community. But I've heard things before too, how somebody had like a bowel perforation or something from getting a psoas treatment. So I don't know if that's true or not, but I've heard that story.
Yeah. So a few muscles are coming up. This one actually, Laura, piriformis.
Piriformis, that's
I remember going to a cadaver lab and actually seeing piriformis, and I couldn't believe how small it was. Like tiny in comparison to like what I remember seeing in Netter. So I just find that really interesting because that's another one of those ones that we blame so much for hip pain, but it's just this tiny little guy that sits in there. And then Connor, before we get into the other muscles, Connor, they ignored the red flags that were going on with the person. So that's too bad for both the therapist and the patient, but especially the patient.
I know from the podcast I was on with Connor, he's really good about the red flag stuff. He's a lot more cautious, I think, than a lot of us are, which is in cases like that is probably a really good idea.
Really.
Like, rather than be like, oh, you'll be fine. You're like, oh no, let's make sure it's not this thing first, which is that's smart. It's a smart idea.
And that's what we should all be doing. Yeah. So a few that are coming up are QL. Jocelyn left 2 comments about QL. She really wants to talk about quadratus lumborum. Laura, glute med, QL again, suboccipitals, QL. QL's popular.
Yeah.
Wonder if we should just look at a bunch of the research around QL and see its association with low back pain and
sure
how much it actually has to do.
My guess, I'm going to say this right now, I'm just going to make this guess, and is I'm sure that you will never, ever be able to equate a singular muscle or a single structure to pain.
Okay.
But I'm just guessing, but I'd wage money on that.
I'm going to agree with your guess.
Yeah. Yeah. But I think it'll be interesting actually to see. I'm very curious, actually. I'm glad that people said that because I'm curious to see what kind of research has been done to look at the role of the QL in low back pain, for example. Yeah.
So here's another point from Jocelyn. She never understood about that in school. That QL, we had to be careful because the transverse processes may shred its attachments with MTAR treatments, but we could go down into the psoas. Wow. I don't think anybody when I was in school said we could shred the attachments of the QL.
Yeah.
So, I never got that kind of attention when I was in school, but that's
I'd actually be curious to see. We'll have to make notes of this and look into this because I'd be curious to see if you could actually palpate the QL accurately.
I doubt it.
Yeah, I'd have to take a look and get a better idea of the kind of anatomy around that area, but I think it'd be where it sits. I think it's considered on the anterior abdominal wall, is it not?
Well, it goes from the iliac crest up to the ribs, and then
but yeah, I mean, I'm curious about that. I don't know. I'm skeptical of everything though. So
yeah. Same with scalenes. Jocelyn, same with scalenes. Had to be careful with TVP attachments.
Right.
You gotta be careful with scaling just because of where they are, and it can be really uncomfortable if you're pushing too hard.
Yeah, it's like, yeah. I remember the scalings. I remember that one too was another one that we spent a lot of time working on. And it seemed like everything that was delicate or everything that was potentially really painful got a lot more attention. And I think it creates this perspective that it's a really important thing to address.
Yeah. And that was certain things. I don't remember what the condition was, but I remember them saying you couldn't treat SCM bilaterally.
Okay.
Possibly compromise the carotid artery, I think was the
right.
And I was like, yeah, I'm not so sure about that, but
really, I don't know.
Yeah, but I remember that it was like
I don't know.
What do you call it? For some reason, I can't think of words this week. Contraindication.
Okay.
Was you couldn't treat SCM bilaterally, but yeah, have we just beat the crap out of a whole bunch of stuff tonight?
That was good.
Is there anything else that we need to go on about? Is there anything else anybody who's listening in wants to talk about? Oh. Yeah, Laura, she's heard that it feels like you're choking people if you treat it bilaterally. Yeah, I would probably feel like that.
I can imagine because you're like,
yeah,
yeah.
I wouldn't like that, but
no.
All right, well, there's another Monday night.
There we go.
And I think we're planning on one in 2 weeks with the group.
Yeah, I think we'll get the 5 of us.
Mm-hmm.
Jocelyn and TJ and Stefania, I think.
I think we had that in the books. So for anybody I'm not sure what we're going to talk about yet, or I don't think we've decided on that yet. So if anybody has any requests of things that you would like us to cover or things that you'd like to jump on and talk about, by all means, send us some messages, but we'll hop on with the 5 of us in 2 weeks. And same thing, if you like these things and you regularly listen in and there's something you want to talk about, if you would like to come on with us, we'd love to have you on. If there's something that you've got a passion about or something that you're really good at that you'd like to share, for instance, Connor, talking about concussions and things like that, we'd love to have you on. Come on for a Facebook Live, and we can continue to help out our profession and help out some other therapists. Yeah. Other than that, have a great night, all. I might pour myself another scotch. And,
I'm getting another glass of wine, I think, now we're done.
Yeah, and we'll see you guys next time. Thanks for listening.
Night.
Yeah.